Good morning, everyone. I am Dr. Poulomi Derai Chaudhuri, and I welcome you all to this lecture on drug resistance in Mycobacterium tuberculosis, its mechanisms and impact. Tuberculosis has remained one of humanity's oldest and deadliest infectious diseases. Despite the availability of effective anti-tubercular drugs for decades, the emergence and spread of drug resistant tuberculosis have become one of the greatest challenges facing clinicians, microbiologists, and public health professionals worldwide. Drug resistant TB not only increases patient morbidity and mortality, but also complicates laboratory diagnosis, prolongs treatment, raises healthcare costs, and threatens global TB elimination efforts. As microbiologists, our role extends beyond identifying the organism. We are responsible for detecting drug resistance accurately and rapidly, interpreting molecular test results, and supporting clinicians in selecting appropriate treatment regimens. Throughout this lecture, we will explore the molecular mechanisms responsible for drug resistance, understand how modern diagnostic methods detect these resistance mechanisms, and discuss their clinical implications in patient management. So, let's begin by looking at the learning objectives for today's session. Before we proceed, let's briefly review the objectives of today's lecture. By the end of this session, you should have a comprehensive understanding of the microbiology and pathogenesis of Mycobacterium tuberculosis, as these concepts provide the foundation for understanding drug resistance. And from the next session onwards, we will explore the molecular mechanisms responsible for resistance to both first line and second line anti-tubercular drugs. We will examine the important resistance associated genes such as RPOB, CATG, and many more, and understand how mutations in these genes lead to treatment failure. We will also discuss the latest WHO classification of drug-resistant tuberculosis, including rifampicin-resistant TB, multi-drug-resistant TB, and so on. Another important objective is to review modern diagnostic techniques. Towards the end of the lecture, we will review current treatment strategies for drug-resistant tuberculosis based on recent WHO recommendations. Finally, we will conclude with recent advances, future research directions, and key take-home messages that will help you integrate laboratory findings with clinical decision making. With these objectives in mind, let's first understand the global burden of tuberculosis and why drug resistance continues to be such a significant public health challenge. Now that we have discussed the learning objectives, let's begin with a brief overview of Mycobacterium tuberculosis and the concept of drug resistance. Understanding drug resistance first requires an understanding of the organism itself. Mycobacterium tuberculosis is an intracellular acid-first bacillus that has evolved remarkable mechanisms to survive within the human host. Its unique lipid-rich cell wall, slow growth rate, and ability to persist inside macrophages make it one of the most successful human pathogens. Unfortunately, the emergence of drug-resistant tuberculosis has complicated both diagnosis and treatment. Resistance is no longer just an individual patient's problem, it has become a major global public health challenge. In the first section, we will briefly review the organism, its epidemiology, morphology. To appreciate why drug-resistant tuberculosis has become such an important topic, let's first examine its global epidemiology and impact. Drug-resistant tuberculosis continues to be one of the greatest challenges in global infectious disease control. Although effective anti-tubercular drugs have been available for decades, drug-resistant TB remains a significant problem in many parts of the world. Resistant strains continue to emerge because of inadequate treatment, interrupted therapy, poor adherence, inappropriate drug regimens, and ongoing transmission within communities. From a public health perspective, drug-resistant TB is particularly concerning because patients remain infectious for longer periods, require prolonged treatment with more toxic and expensive medications, and often experience poorer treatment outcomes than patients with drug susceptible disease. The economic burden is also substantial. The cost of diagnosing and treating multi-drug resistant or extensively drug resistant tuberculosis is many times higher than that of drug susceptible TB. In addition to healthcare costs, there are indirect costs due to loss of productivity, prolonged hospitalization, and long-term disability. Now let's look at the major risk factors that contribute to the development of drug resistance. One of the most important factor is poor adherence to treatment. When patients fail to complete the full course of therapy, drug susceptible bacilli are eliminated while naturally resistant mutants survive and multiply. Other important risk factors include inappropriate treatment regimens, incorrect drug dosages, poor quality medications, delayed diagnosis, and direct transmission of already drug resistant strains from one individual to another. Therefore, drug resistance develops not because antibiotics create mutations, but because antibiotics select naturally occurring resistant mutants when treatment is inadequate. So, what is the clinical pearl here? As microbiologists, timely laboratory diagnosis and accurate drug susceptibility testing are essential to ensure that patients receive effective therapy as early as possible. Having understood the global burden and the factors driving drug resistance, let's now take a closer look at the organism responsible for this disease, Mycobacterium tuberculosis and Mycobacterium tuberculosis complex, that is, in short, MTBC. Before discussing the mechanisms of drug resistance, it is important to appreciate the current global burden of tuberculosis. According to the WHO Global Tuberculosis Report 2025, tuberculosis continues to be one of the leading infectious causes of death worldwide. In 2024, an estimated 10.7 million people developed tuberculosis globally. Despite major advances in diagnosis and treatment, approximately 1.23 million people died from TB, excluding deaths among people living with HIV. These numbers remind us that tuberculosis remains a major global health challenge. Drug resistant tuberculosis is an equally serious concern. The most important message from this slide is that tuberculosis remains one of the world's leading infectious diseases, and drug resistant TB continues to pose a major threat to global TB control. The exact figures are shown on the slide for your reference. These statistics clearly demonstrate that drug resistant tuberculosis is not merely a microbiological problem, it is a clinical, epidemiological, economic, and public health challenge that requires coordinated efforts from clinicians, microbiologists, public health authorities, and policymakers. As microbiologists, we play a crucial role in this effort by ensuring rapid and accurate laboratory diagnosis, detecting drug resistance at the earliest possible stage, and supporting appropriate patient management. Having understood the magnitude of the problem globally, let us now examine why drug resistance is so important from a clinical and public health perspective. Drug resistance has important consequences at multiple levels, affecting the laboratory, the patient, and the society as a whole. First, from the diagnostic perspective, drug resistant tuberculosis requires much more than routine smear microscopy. We increasingly rely on rapid molecular diagnostic techniques such as GeneXpert MTB or RIF Ultra, line probases, and in selected settings, whole genome sequencing to identify resistance associated mutations quickly. Expanded drug susceptibility testing is also essential for selecting the most effective treatment regimen. Second, let's consider the clinical impact. Patients with drug resistant tuberculosis are more likely to experience treatment failure because the standard first line regimen is no longer effective. As a result, treatment becomes longer, often lasting many months, and involves second line drugs that are more expensive and may cause significant adverse effects. These patients also have a higher risk of mortality and may continue to transmit resistant strains if diagnosis and treatment are delayed. Finally, the public health impact is substantial. Drug resistant tuberculosis threatens the success of the WHO NTB strategy. It increases the burden on healthcare systems by requiring prolonged hospitalization, specialized laboratory services, and costly medications. More importantly, continued transmission of resistant strains can lead to the emergence and spread of increasingly resistant forms of tuberculosis, making disease control even more challenging. Therefore, combating drug resistant tuberculosis requires an integrated approach involving rapid diagnosis, effective treatment, strict infection control, continuous surveillance, and strong public health programs. Having understood the clinical importance of drug resistance, let's now revisit the organism itself by reviewing the microbiology and basic characteristics of Mycobacterium tuberculosis before we explore the molecular mechanisms of resistance. Having discussed the epidemiology and clinical significance of tuberculosis, let us now briefly review the taxonomy of the organism. When we use the term Mycobacterium tuberculosis, we are often referring specifically to the species that causes the vast majority of human tuberculosis. However, it is important to remember that it belongs to the Mycobacterium tuberculosis complex, commonly abbreviated as MTBC. The MTBC consists of several genetically closely related species that share more than 99.9% genomic similarity, yet they differ in their preferred hosts, geographic distribution, and epidemiological significance. The most important member is Mycobacterium tuberculosis, which is responsible for the overwhelming majority of human tuberculosis worldwide. Mycobacterium bovis primarily infects cattle but can also infect humans, usually through zoonotic transmission. It is particularly important because it is intrinsically resistant to pyrazinamide, a point that is frequently asked in MBBS, MD, and DNB examinations. Another important member is Mycobacterium africanum, which is predominantly found in West Africa and accounts for a proportion of tuberculosis cases in that region. The remaining members, including Mycobacterium caneti, Mycobacterium capri, Mycobacterium microti, Mycobacterium pinnipedi, are relatively uncommon causes of human disease, but are epidemiologically important because they demonstrate the wide host range and evolutionary diversity of the MTBC. From a microbiologist's perspective, understanding these species is important because differences in host preference, epidemiology, and intrinsic drug susceptibility may influence laboratory diagnosis and clinical management. For most routine clinical laboratories, however, the primary focus remains the identification and drug susceptibility testing of Mycobacterium tuberculosis, as it is by far the most clinically significant species. Remember the most important Viva question: which member of Mycobacterium tuberculosis complex is intrinsically resistant to pyrazinamide? Write the answer in the comment box. Now that we have reviewed the taxonomy of the organism, before moving into its microbiological characteristics, I would like to acknowledge the major scientific references that have been used in preparing this lecture. All the information presented in the previous slides has been compiled from internationally accepted and evidence-based sources. The epidemiological data have been taken from the WHO Global Tuberculosis Report and the WHO Consolidated Guidelines on Tuberculosis. And the following references have been used as mentioned in this slide. Let's now end the today's session. In this introductory part of the lecture, we have reviewed the global burden of tuberculosis, understood why drug-resistant TB has become a major public health concern, discussed its clinical significance, and briefly introduced the taxonomy of the Mycobacterium tuberculosis complex. These concepts provide the foundation for understanding the molecular mechanisms of drug resistance, which will be the focus of the next part of the lecture series. In the upcoming session, we will begin with the microbiological characteristics of Mycobacterium tuberculosis, including its morphology, unique cell wall structure, virulence factors, and how these biological features contribute to intrinsic drug resistance. We will then gradually move into the molecular basis of resistance to individual antitubercular drugs. I hope today's session has provided a clear overview and a strong conceptual framework for the topics ahead. Thank you all for your time and attention. If you have any question or points for discussion, I would be happy to answer them. Please mention those in the comment section. Thank you. I will see you in the next session. If you found this lecture helpful, please consider liking the video, sharing it with your colleagues and students, and subscribing to Medical Microbites. Your support motivates me to continue creating evidence based microbiology lectures. Thank you, and I will see you in part 2.